Friends, good evening. Welcome to Indian Arthroscopy Society webinar today. It's our webinar number 115. We are going to talk about a very, very important and interesting topic pertaining to the young arthritic shoulder. Where are we today? Dr. Shreyash has been kind to arrange this webinar with a master of shoulder surgery today with us, Professor Joseph Abboud. He's joined us today from Rothman's Institute, Orthopaedic Institute, Philadelphia, US. And he's Director of Research of Shoulder and Elbow Division, the C.D. Kimmel Medical College, Thomas Jefferson University. I'm also extremely thankful to Dr. Ram Chidambaram, President of the Shoulder and Elbow Society, to have joined on the panel today. Shreyash would briefly introduce our guest speaker today, followed by his presentation. You please send your questions on our chat box of Indian Arthroscopy Society YouTube channel, as well as our Facebook live chat box. Shreyash, please.
Yeah, thank you, Dr. IPS Oberoi, and hello everyone, and welcome both the Shoulder and Elbow Society and the Indian Arthroscopy Society colleagues to this webinar on the young arthritic shoulder. Where are we today? Glenohumeral arthritis in the young adult patient is a difficult condition given both the age and the functional demands, as shoulder arthroplasty may not be ideal in this population. And to give us his experience and share his practice on this topic, evidence-based, we have Dr. Joseph Abboud from Philadelphia, USA, who is an internationally recognized surgeon in the treatment of shoulder and elbow disorders. He's a professor of shoulder and elbow surgery, the Sidney Kimmel Medical College, Thomas Jefferson University, Rothman Orthopaedic Institute. He completed his residency in orthopedic surgery at the Hospital of the University of Pennsylvania. He subsequently completed fellowships at the University of Pennsylvania in shoulder and elbow surgery and orthopedic biomechanics. He actively participates in regional, national, and international orthopedic societies and serves on various national committees in leadership positions. He has presented over 500 lectures nationally and internationally, and is the author of over 200 scientific articles and several textbook chapters. And really, he is the apt person for this difficult topic. And on behalf of both the societies, I'm very grateful for him to accept this invitation. And I would kindly request him to please share his screen and give us his talk on this topic. Thank you.
Thank you for that wonderful introduction. I really appreciate the honor of being able to speak to the Arthroscopic and Arthroplasty Shoulder Elbow Society. So I hope this meets your standards, and I look forward to your questions at the end. And hopefully one day.
I think it's not advancing. If you could please click on the bottom left on the screen to advance it.
I think Dr. Joe, you just double click on the screen, double click, just go for a double click. I think it will advance.
For some reason I'm getting
you need to reshare it again. I think you have very unstable connection.
okay.
Yeah.
You can see me now?
Yeah. You can run the slideshow now.
Okay. Do you see it?
Yeah.
Great. So my disclosures are available in the Academy website. Just to start our thought process as we think about this problem during this lecture, you have a very common situation, a 44-year-old administrative assistant, arthritis of the dominant arm, x-rays show an inferior osteophyte, MRI shows that the rotator cuff is intact, there's no substantial glenoid wear, and they failed conservative management. And this is the problem that we have. And these are the solutions that we have. We have do nothing, which sometimes is the best option. Scope debridement, capsule release, biceps tenotomy, subacromial decompression. We have the CAM procedure, comprehensive arthroscopic management, which we'll talk about later more. Biologic arthroplasty, resurfacing with glenoid biologic, hemiarthroplasty with a biologic on the glenoid, a standard TSA, and a TSA with a convertible stem. All viable options. We know that the treatment of arthritis in older population has been very effective, and we have increasing rates of utilization with excellent pain relief and range of motion and good survivorship of the implants. But we have this, we have the very active individual with loss of cartilage, bipolar lesions many times, and significant pain. And we have these patients that unfortunately sometimes don't really get the seriousness of the problem and the reality of their body giving out, and they want to continue to push. We've seen many different etiologies of why this comes about. In our younger population, we've had issues with chondrolysis, and there's a variety of etiologies. Years ago, it was very common issue, secondary to pain pumps, but also seen to be common sometimes with prominent suture anchors, thermal damage, knot abrasion, infection. And this is a rapidly increasing segment of our younger population. Oftentimes, potentially what I see is either unindicated surgery or poorly performed surgery. Inflammatory arthritis, this thankfully has gotten better. As medical management has improved, we see less of these patients that have premature severe arthritis. In this patient population, traditionally, we used to say hemi was the treatment of choice, but oftentimes we now are putting in glenoid components as well in this patient population. But again, this patient population has decreased significantly in the last 20 years due to excellent medical treatment. As far as instability, I think it is challenging, not just from the sense of patients who have repeated episodes of instability, but also the treatment of instability itself can oftentimes recur, cause progression of arthritis. We have issues oftentimes with the operation being done poorly, over tightening the shoulder, particularly with some of the historic instability operations, such as the putty plat, the Eden Hybenet. They have shown high rates of arthritis. As far as the Bankart repair, less alteration of anatomy. In the United States, we still use the arthroscopic Bankart pretty routinely and do use the ladder J, but much more conservatively than our European counterparts. Obviously, when indicated, the ladder J procedure is a good procedure, but it has to be done technically right and can sometimes lead to some really terrible complications involving the glenohumeral joint and premature arthritic change. We still see patients who, for various reasons, develop osteonecrosis or AVN. These patients are oftentimes younger, and this can be a devastating problem for multiple joints. And we know the risk factors for that as well. Treatment can be in the early phases with things like core decompression, and this is something that I will do on a case-by-case basis, oftentimes arthroscopically with fluoroscopy assistance. But in some cases, it's too advanced, and you need to consider your arthroplasty options in these patients. We routinely have patients come in with glenoid dysplasia and hypoplasia. And typically in this patient population, you'll see underdeveloped posterior inferior glenoid and glenoid scapular neck, enlarged labrum. And this does predispose these patients to to, unfortunately, early OA. This patient population is particularly challenging as their anatomy is distorted. You have limited glenoid bone stock to work with. And oftentimes they're still in their 30s or 40s, and corrective osteotomy will likely not work in this patient population because the arthritis is already advanced by the time it's caught. If you look at some of the series here, one of them by Cofield, 22 patients, average follow-up of 6 years with glenoid dysplasia. 50% had hemis that had to be revised to TSA due to progression of glenoid arthrosis, but glenoid placement also had some problems. But in general, in this patient population, we tend to do, if we have time, I'll show you a case, we tend to do total shoulder arthroplasty and playing it where it lies, as they say. Some patients develop this progressive arthritis of unclear etiology that parallels older patients, in which they start developing early B2 glenoids with posterior subluxation and posterior glenoid erosion as well. Again, I'll touch on our weightlifters. They're a unique population. They are patients that will oftentimes want an operation so they can continue to just lift, and you have to be very careful in selecting these patients for the right operation. Workup, as always, is important in this patient population. If nothing else, spending more time and being more thorough because of their young age and sometimes their lack of maturity. These patients can sometimes make reckless decisions for treatment that they're not happy with later on. So I spend a fair amount of time trying to distinguish where their pain is coming from, making sure it's shoulder, understanding their history, and oftentimes they'll minimize it for things like trauma, what their demands are, what they do as far as their job, physical labor, and athletic activity, any relevant medical history. Previous operation history is very important, and asking questions that they may not be cognizant of, like was there any wound drainage, wound healing problems, repeat incision and drainage, and assessing their range of motion and how much loss they have of range of motion will affect their ultimate outcome from any intervention you perform. Start off with radiographs to assess this, trying to get a good series of AP, internal, external rotation, axillary and scapular Y, can really tell you a lot about their disease process, the amount of joint space, subluxation, erosion, medialization, and the type of arthritis they may have. MRI is oftentimes something they come in with and is useful, obviously, to assess the integrity of their rotator cuff and soft tissues, especially if they've had previous open operative intervention in violation of their subscapularis. Can also give you a sense of how much cartilage loss they have. In some situations, particularly if you're considering arthroplasty option with the continuing advances in patient-specific instrumentation and templating, CT scanning can be utilized and useful. Make sure in your workup that you don't minimize the role of potential infection. And there have been increasing number of papers coming out from multiple institutions, including ours, on the difficulty of diagnosis of infection, particularly with C. acnes now. And they may have very normal labs, may want to consider aspiration. And if you're going down the arthroplasty route, may want to consider a diagnostic arthroscopy prior to surgery with multiple cultures to see if there is any indolent infection. And remember, these cultures typically have to be held for 14 days to make sure you're not getting a false negative. Treatment in the early stages, as always, there is a role for conservative management with various modalities, such as activity modification, NSAIDs, some therapy, limited role of corticosteroid injections. In my practice, I will use them very rarely. I'll tell patients I'll do 1 a year, maximum of 2 to 3 injections, and that's it. At that point, they either have to resolve to live with the problem or decide on what's appropriate treatment. Fiscal supplementation may have some promise. In my hands, I have not seen that much of a benefit. There have been studies on it to show that it has some limited efficacy, but I often tell my patients, quite honestly, they probably could spend their money on something else. It's not covered by insurance in the United States and can be anywhere from $500 to $900 for an injection. This is the area that currently studying. We're doing a multi-center prospective study on arthroscopic treatment to look at this in a level 1 evidence fashion. And if you look at the data going back all the way to 2000 with Dr. Bigliani, they looked at arthroscopic debridement of the shoulder. And you can see that they had 25 patients, did a variety of treatment modalities, and at 3-year follow-up, 80% had good to excellent results. And they made the recommendation that if you still have joint space visible and the arthritis is concentric, that it's a reasonable option. And I think we still follow that rule 20 years later. You'll see a lot of these studies kind of reinforce that. This is another study from the University of Pennsylvania. 61 patients, a larger cohort. 45 patients had 2-year follow-up. 88% of patients reported pain relief and improved range of motion. And they recommended that if the lesions were greater than 2 centimeters in size, the patients oftentimes would not have a successful outcome. This analysis by the Rush group, 81 patients, and they noted that patients who had bipolar lesions, again involving the glenoid and the humerus, 87% required arthroplasty. Other risk factors were, as the Bigliani study showed, decreased joint space, large osteophytes, and increased grade of arthritis. Italian study of 47 patients incorporating debridement with microfracture saw SST increase and constant score increase. And again, patients who had poor results had further progressive arthritic changes and a square humeral head. And they, again, also found that smaller lesions tended to do well. And this has been my experience as well. Now we get into Peter Millett's description of the CAM, Comprehensive Arthroscopic Management Procedure. And again, a common theme here, patients can do well if properly selected. They can see an improvement in their overall level of function ASCS scores. However, patients who required osteophyte resection were less satisfied, likely from the fact that their arthritis was more severe. And if their joint space was narrower, they were more likely to require an arthroplasty. All things to consider when you're counseling your patients. This was a look at the literature of 5 studies from the WashU group. And they found in this cohort, mean age was 49 years. They had significant improvement. Surprisingly, only 13% of these patients during this study time underwent conversion to arthroplasty. If you look at another paper by Peter Millett, kind of hedges his bets and says if you're less than 47, arthroscopic management may be the way to go. Between 47 and 66, it's sort of dealer's choice, and over 66, TSA is probably preferable. And I think that's a reasonable guideline to think about. I don't think anything fits into one sort of silo all the time, but it's a reasonable way that I try to counsel my patients on what to do. I think if they're young, they have concentric where they have some joint space left with minimal osteophyte formation. Scale of 1 to 10, I'd say anywhere between a 1 to a 5, I'll consider arthroscopic management. When their severity of arthritis goes beyond that, I tell them it's really likely not to benefit them that much, and they may need to either try to hold on as long as possible or consider arthroplasty if they're in the proper mindset and have had appropriate counseling. This was a study from WashU looking at their cohort of patients. They actually did fairly poorly. They had initial improvement, but only for 4 months. 61% were not satisfied, and 42% of patients had an arthroplasty 9 months post-op. So clearly this group did not do well. So arthroscopic recommendations is reasonable for patients with concentric glenohumeral arthritis, at least 2 millimeters of preserved joint space, small unipolar lesions, and up to and including grade 4 lesions with small osteophytes. I do like to do a capsular release. I know it's controversial. Some people argue that if you increase motion, you increase pain. Others argue that if you increase motion, you decrease contact pressures, which may improve pain. I tend to believe that if you do a capsular release, you increase motion and decrease contact pressure. Now we're going to move into the arthroplasty portion of this conversation. So hemiarthroplasty can be indicated in patients who are young, active, and have avascular necrosis or severe unipolar disease. And you can see here an X-ray of a pyrocarbon implant. I'd be interested in seeing if you've had experience with that at this point. Contraindications are poor bone quality, obviously rotator cuff deficiency, extreme stiffness, and any history of infection is a relative contraindication depending on the organism and how it was treated. Things to consider when you're doing a resurfacing arthroplasty is the size. The most common mistake people make here, and the most common mistake I see when patients come into my office after an operation, is the dimensions. They were overstuffed. And you need to understand the deformity that happens in the arthritic process, and that you're trying to recreate their anatomy pre-morbid condition and try to avoid overstuffing the joint. So you want to, and it seems like a simple operation, and oftentimes people feel like they don't need to get the same exposure, but it's important that you get an excellent exposure of the humerus and glenoid in this operation, just like you would for a total shoulder arthroplasty, so that you can see where the rotator cuff inserts, you can see the bare area, and you can ream the head appropriately to prepare it for the implant. And in this situation, the correct position is crucial, because once you've bought that position, and if you put them in too much varus or too much anaversion or too much retroversion, then the rest of the procedure is based off that starting guide. So it's really important to be accurate with that and to spend some time learning the system if you're going to use it. Again, I can't emphasize enough, avoid overstuffing. I constantly tell my fellows throughout shoulder arthroplasty procedures, undersize or revise. The loosest the shoulder will ever be will be on the table. It will never be looser. And these patients, when this is performed, and this is a very small subset of patients in my practice, undergo a very similar rehab protocol to most of my arthroplasty patients as far as protecting the subscap and progression of range of motion and then progressive strengthening. Glenoid interposition arthroplasty, I mentioned more in my experience from a historic perspective, not so much from something that I actively utilize in my practice at this point. It was popularized by individuals such as Buzz Burkhead, Mike Worth, De Beer, and oftentimes this is utilization of either the lateral meniscus, Achilles tendon allograft, dermal allograft, or even the joint capsule. It requires a fair amount of work as far as glenoid preparation and reaming and drilling to vent the glenoid, and then attachment of the graft with either anchors or suture through the remnant labrum. And you can see here a case example of someone who needed glenoid interposition with a dermal graft. You can see the preparation to get a bleeding bed, multiple placement of suture anchors, sizing of the graft, passing the sutures through the graft, and then placing the graft. Unfortunately, in these cases, oftentimes what was seen is that these grafts on second look would oftentimes be bunched up in the back of the joint and not be present anymore. So for me, it's not something that I utilize. I think there are good techniques out there that are described for even arthroscopic implantation by De Beer. I think these are for for very young patients who have unipolar disease, and obviously has to be done in the hands of a expert arthroscopist to be able to pull this off. So we know from our colleague at the University of Washington, Rick Mattson, the ream and run, or sometimes as we call it, the ream and scream, the ream and run away, the ream, run and revise, the various little nicknames for it. He's had very good success with this procedure. We've had experience with it. We've had some success, but also a fair number of failures. The thought behind this is reaming to create a glenoid articular surface that has a slightly increased radius of curvature compared to the humeral head that's going to be implanted. You want to stimulate fibrocartilage on the glenoid. It's typically better in patients around the age of 60 or so, but the concern with it is the preservation of glenoid bone, which you end up reaming some away, as you can see from the schematic on the right. We tend to find that patients who have this tend to have to have a high pain tolerance to go through the rehab, particularly the first year. We also know that if patients fail this, the results of conversion of a hemi to a total is not as good as a primary anatomic total shoulder arthroplasty. So you do burn a bridge, even though you think that, well, I'm preserving the glenoid and that's better for them. Well, true, but if you have a suspicion that this is going to be unsuccessful, then potentially going to the total shoulder may have been a better option. I tell my patients if they're going to have a hemiarthroplasty that they should expect the pain level to be about 65% improved versus a total shoulder arthroplasty, probably 90% improved. So while operations that preserve the glenoid bone, as I was saying, are appealing, TSA with the glenoid component insertion is more reliable in terms of pain relief and range of motion. And you can see from various studies I've noted here, Cofield et al. Showed improved pain relief, range of motion, and implant survival in TSA when compared to hemi in patients less than 55. And Dillon et al. Showed hemi significantly more likely to be revised in population less than 59 than a TSA, most commonly due to glenoid arthrosis. In this analysis systematic review by the Rush group, young was defined as less than 60, 32 studies, and it concluded that a lot of this data was level 4 data. Concluded that TSA provides greater improvement in pain relief and range of motion in young patients with glenohumeral osteoarthritis. And again, I think if you counsel the patient properly it's not to say that hemiarthroplasty can't be utilized, but you have to set appropriate expectations for these patients. If you look at this study by Dylan, 504 patients in the Kaiser system, which is a large health system in California, under 59, undergoing shoulder arthroplasty, 220 totals, 207 hemis. And if you look at the predictors of revision, younger age was a predictor of revision. Hemiarthroplasty had a higher rate of revision than total shoulder, and a resurfacing type of hemiarthroplasty had a significantly higher rate of revision than anatomic total shoulder. So the future of how we decide, you're gonna have to look at many factors: functional outcomes, survival, and cost. And this was a study out of our institution, published in Core, to try to create a decision model to evaluate cost effectiveness of hemiarthroplasty versus total shoulder arthroplasty in young patients. And it utilized the Markov chain decision tree and the Monte Carlo simulation in patients aged 30 to 50. The outcome variables that were looked at are implant survival, satisfactory years, as well as cost up to the age of 70, including facility, surgery, surgeon fees, and anesthesia reimbursement. Found that a TSA resulted long-term in greater cost saving, avoided a substantial number of revision surgeries, and greater years with quote-unquote satisfactory outcomes. However, the disclaimer that needs to be noted here is this is a per patient selection for treatment, and this remains important in the decision process with our patients. Reverse total shoulder arthroplasty obviously has seen a tremendous increase in utilization for a variety of reasons. I think it's something that has to be carefully considered in severe situations and clearly not overutilized, but it may have a role in some of these salvage situations. Again, in these situations, extensive counseling, second opinion, making sure the patient understands what they're getting into is critical. Now, total shoulder arthroplasty itself also comes with a caveat. When patients have a glenoid component implanted, it may be surviving, but radiographically can sometimes appear to be at risk, as shown by studies by Cofield and Walsh. And so when I look at this, if I think about sort of my treatment, TSA is likely my treatment of choice in informed, compliant young patients with glenohumeral arthritis that's not amenable to arthroscopic treatment, who've exhausted non-operative treatment, and who've gotten appropriate counseling from myself and oftentimes a second opinion. These young patients are unique in the sense that they've not been through a lot in life. My senior partner, Jerry Williams, always says it's very different dealing with a 35 or 40-year-old than a 60-year-old. Oftentimes that 60-year-old's been through knee replacement, a heart attack, a divorce, life's beating them down. They understand that life isn't perfect and neither are surgeries. Whereas a 35, 40-year-old, 42-year-old may not quite grasp that concept and may be dissatisfied despite an excellent operation. Is fusion still have a role? And I mentioned this because I think people need to know about it and realize that there are situations where it may be a salvage, just like a resection arthroplasty, particularly in people who've had multiple failed instability operations or patients who've had multiple failed arthroplasties and have had a history of problems with infection, nerve dysfunction, cuff dysfunction, deltoid dysfunction. Indications for these types of procedures: post-traumatic arthritis, brachial plexus injury, deltoid and rotator cuff muscle deficiency, failed instability, tumor resection, and failed shoulder arthroplasty. Relative contraindications: periscapular muscle nerve injury, poor scapulothoracic function, elderly osteoporotic patients, neurologic disease, and neurogenic arthropathy or Charcot arthropathy. In this patient population, oftentimes you do need radiographs and a CT scan to assess the anatomy and degree of bone loss. Occasionally, you may need an EMG to document neurovascular status, particularly of the periscapular muscles, deltoid, and or the rest of the extremity brachial plexus. MRI is rarely required. If you're going to do an arthrodesis, and again, this is not commonly done, but sometimes it's necessary, you need to make sure, especially if there's a dominant extremity, the positioning allows them to reach their mouth. You do not put them in so much abduction and external rotation that it causes excessive winging on the scapula, fatigue, and pain, which can be a problem. And you can see the recommendations. I won't go through these in great detail, but somewhere around 20 degrees of abduction, 30 degrees of flexion, and about 40 degrees of internal rotation seems to be a good position for the fusion. Two fusion techniques. There's intra-articular fusion between the humerus and the glenoid, which is my preferred technique, or there's this extra-articular fusion, which you see here, which is fusion of the humeral head, glenoid, and the acromiohumeral interval as well. These patients are managed conservatively to make sure you have bone healing and then progress. In this patient population, again, this is a study looking at patients with brachial plexus palsies, and they had average follow-up of 25 months. They used pelvic recon plates, which is what I use for shoulder arthrodesis when necessary. It works well, allows you to use potentially, oftentimes, 6-5 screws. Complications, there are definitely some. Non-union, malposition, potential for infection, especially since these patients have had usually multiple previous operations, and then the risk of hardware prominence and periprosthetic fracture. So again, when I think about my young patient, and I see this a lot these days, I try to educate them about the treatment options. I have multiple visits with them. I try to develop a relationship with them. I need to understand their psychology. Oftentimes, I make sure that they've seen one of my partners, and then that they agree it's an appropriate next step in treatment. As I said previously, oftentimes their maturity level is not quite there. I do use arthroscopy quite a bit, as I do think it does not necessarily burn any bridges, especially for the patient who is having severe pain, is exhausted conservative measures, and is not ready for an arthroplasty. But I do lean towards the total shoulder versus a hemiarthroplasty when the activity level is appropriate. Otherwise, I make sure that they're appropriately counseled on the level of pain relief to expect. I have some experience using the pyrocarbon. The United States had an investigational device trial through the FDA for the pyrocarbon. My patient population for that was on the younger side due to severity of their problem. I had one patient who was 25 and I have about 5 years outcome at this time. With the pyrocarbon, it was a hemiarthroplasty procedure. I've seen some encouraging results, even though I must say that I'm not entirely sure that glenoid erosion is avoided with the use of pyrocarbon at this point. But their pain levels and satisfaction so far are generally pretty high. And again, these are some of the implants that are available around the world. The one on the bottom right is what's available in the United States. That's available through Wright Medical, which is now obviously purchased by Stryker. So in conclusion, young patients with glenohumeral arthritis present a unique diagnostic and treatment challenge. Can't overemphasize enough the thorough H&P and radiographic analysis is important to distinguish possible secondary causes of the arthritis and make sure you plan the surgical intervention properly. Again, first do no harm. Non-op management is a mainstay of treatment in this population. TSA in my hands generally provides better pain relief, range of motion, and lower risk of revision. Glenoid component loosening still is a concern. And patient selection, as always, is critical. So with that, I will stop lecturing and we'll turn it over to the chat. I also have cases we can go through if you'd like. I'm open to whatever you'd like to do.
Joe, we have time. So if you want to run through some cases and then we can have the discussion.
Sure. So this is a 26-year-old right-hand dominant female. 7 years ago, she had a labral repair with an intra-articular pain pump. She had progressively worsening shoulder pain, had a recent work injury, was a pretty minor mechanism. We did scope her to see what her joint looked like. And this is what her joint looked like. No cartilage on the glenoid or the humerus, consistent with this chondrolysis pattern that you see. Severe pain and severe limitation of motion. These are x-rays, and you can see on the axillary, concentric glenoid, but really minimal joint space with an inferior osteophyte. And remember, again, 26. Spent a long time counseling this patient on her options. She'd already had an arthroscopic treatment that failed. So options in her, ended up doing a total shoulder arthroplasty. I did her operation probably 7 years ago now. And she has done well. Do I worry about her? Absolutely. What other options could I have done? Well, I could have done a hemi. I was concerned, though, she'd continue to have glenoid pain. Could have considered a fusion, but most people are not interested in that operation unless they have had extenuating circumstances of multiple operations and are in severe pain. So this was the best choice I could give her. And I think that so far it's worked out reasonably well, but I can tell you, I did exactly what I said in my talk. I had her see me multiple times, develop a relationship, have other opinions, make sure that we all understood what we were getting into. And she's had an excellent outcome. This is a 48-year-old female, left shoulder pain, increasing pain, interfering with daily activities, has a history of lupus anticoagulant, but no history of DVTs. 140 bilaterally, external rotation 45, no lag signs. Still decent range of motion. You can see on the x-rays, you get a sense on the AP, there's medialization of the joint line, something not quite right with the glenoid morphology. You see the osteophyte off the humeral head. And you see on the axillary view, the shape of the head is mal-shaped, and also there's looks like an underdeveloped glenoid. If you look at our CT cuts here, so this is a 3D reconstruction, and I think this shows it better than all the x-rays. You can see the hypoplastic glenoid, the shortened neck. And this patient The options were, again, arthroscopic treatment, in my experience, for something like this does not work. Hemiarthroplasty, she's 47. We ended up using a 3D model to recreate her anatomy and plan this. And then we placed the glenoid. We did a total shoulder and placed the glenoid where it lies. So played it where it lies because it was not subluxed. This is something that my partner, Jerry Williams, believes in strongly. If they're not subluxed, just put the glenoid where it lies. Don't try to overcorrect it with an augment. And so you can see here, dysplasia and erosion of the glenoid. You can see here we're using, this is a glenoid made by Arthrosurface, which is a small insect glenoid. You can see how we prepare it and lays in there. And then that's a DePuy Global Unite stem that can be converted in the future if necessary to a reverse shoulder arthroplasty. So it's a convertible stem. I'll show one more case. This is kind of interesting. This is an instability case. 47-year-old female fell January 2012. Felt a pull in her shoulder, possible subluxation, but did not think she dislocated, and nothing required a reduction. Didn't see anybody for a month. Then diagnosed by an outside physician with a glenoid fracture, but did not want surgery at that point. But she did have a persistent feeling of slipping in her shoulder. Failed PT and had an arthroscopic Bankart repair in March of 2012. And this was pictures from the surgeon who performed the procedure outside facility. You can see a chondral flap on her glenoid. You can see they did a Bankart repair. And you can see a Bankart tear in the top left. She states that after surgery, she still felt feelings of instability, especially with overhead activity. Never still needed a formal reduction of her shoulder. She's had PT for multiple months after the procedure, is taking anti-inflammatories routinely at this point, daily. Pain at rest. And the original surgeon had scheduled her for a lateral J procedure, and she was seeking a second opinion. And so complex history and not uncommon for the type of patient that we see. It's been operated on, many concerns, instability, glenoid cartilage defects, and constant continued pain and feelings of instability. Range of motion was not great, but painful. 130 of forward elevation, external rotation of 30, abduction, external rotation of 70, internal rotation to L5. Cannot really load and shift there, but does feel somewhat guarded and apprehensive, but it was difficult to fully understand. Rotator cuff strength was intact. No signs or symptoms of infection, neurovascularly intact. She is a recovering alcoholic, sober for 7 years, does suffer from a depression, but is otherwise a motivated patient. These are her x-rays in November of 2012, so after the operation. You can see that the glenoid, where the glenoid fracture happened and the medial sort of healing of that. See some maybe cystic changes in the glenoid as well in the x-ray. You can see on the MRI, particularly the bottom right here, potentially some changes in the chondral surface. And again, the MRI suggests some bone loss. And this is her CT scan. So she's had really $1 million workup for this problem. You can see the malunited glenoid fragment. You can see it on the axillary cuts as well. So the dilemma here was, is this lady suffering from further instability? And this is sometimes hard to tease out. Or is she having more of a problem with some sort of early arthrosis? And also potentially sometimes an over-tightening phenomenon that we see when patients have a stabilization procedure, especially females in their 40s, who are sometimes prone to post-traumatic capsulitis. So we really had everything on the table as far as what we would do operatively, meaning we had consented her for various options. So consented her for possible ladder J. Did not think that an allograft was necessary. And I'm not somebody who goes to the iliac crest primarily. I tend to use the ladder J first. Would you do shoulder arthroplasty in her? I think that would be very aggressive and quite frankly unindicated. The other option that I thought was something to think about, and I've seen this, is examination under anesthesia to see if she's having more of a problem with stiffness and is having pain because of increased contact pressures and arthrosis. And I thought about that as well and had arthroscopic evaluation, capsular release on the consent with cartilage restoration procedure using micronized extracellular matrix cartilage product. So we did an EUA. She had no instability of the shoulder, but deep crepitus with range of motion. And this is what we saw at the time of her surgery. Let's see if this starts. So you can see she has a chondral defect. You can see I've already microfractured it. And I decided at this point that I was going to go with a cartilage restoration procedure. So I removed all her sutures, prepared the bed. This is a dry scope now. First I did a wet scope, then I did a dry scope, and used this system that's available through Arthrex to implant this basically dehydrated cartilage material into the defect. And actually, it's pretty straightforward to use. I'm not a paid consultant for Arthrex, just to be clear. And then you seal it with a fibrin glue in place and let it dry, and then take it through a range of motion to make sure there's no areas where it's pulling off, etc. You can see the before and after. And I also did a capsule release on her, and this case was very educational for me because I learned that, you know, sometimes it's the subtleties of what you find and the solutions that end up being very valuable to the patient and minimizes their risk for larger operations. And she's done very well. I've actually seen her for her other shoulder. And this shoulder now is 5 years post-op, excellent range of motion, and she's in her early 50s now. So with that, I think I'll stop and take any questions that you all have.
Great. Thank you.
Yeah, could you please unshare, Joe? Great. Thank you very much for that excellent overview on this difficult topic and also very interesting cases. I just invite my co-panelists to please start the discussion, and then I'll ask some questions towards the end.
So, Ram, you can start the questions.
Thank you, Dr. Joe. This is a fantastic covering of all the options. I think the treatment of young arthritis is a challenge. And I agree that it has to be individualized to that particular patient's demands and the scenario. Now, I got a couple of questions. First is, in the both examples you show, you have used the stemmed prosthesis for the humerus. Is it for a particular choice you wanted to replace the glenoid, or would you have done a resurfacing with resurfacing of the glenoid as well?
So at the time I did both those cases, the stemless was not available in the United States. So the stemless has been available for about 5 years. So I would have done a stemless at this point. So for my anatomics with good bone stock at this point, I do use primarily stemless arthroplasty, anatomic arthroplasty. But at the time I did those, that was not available.
Okay, so that's your current choice for a young arthritic shoulder when we want to replace humerus would be stemless arthroplasty?
It would be stemless, and I'll tell you why. Just because I think you get really good at things you do a lot, and I think I do a lot of humeral cuts and emplacements of short stems or stems. I don't do a lot of resurfacings, and I think it's very easy to, in those situations, not put them in the right position or overstuff them. And so I think that, and if I was training in Reading, England with Ofer Levy and doing, 100 resurfacings, I'd probably do all resurfacings. I think it's really comfort level.
Okay, and that's because that's the risk of overstuffing with the resurfacing, and stemless seems to be the better option, mixing of the best of the both worlds. My another question is that when you do a replacement for a young arthritic shoulder patient, what will be your advice on lifting weight, heavy manual labor? Or will that be according to your choice of prosthesis?
So
will you ban it, or will you say not to overuse it? Or?
So yeah, I do. I mean, if they're a laborer or someone who participates in contact sport, then I will tell them that they're better off getting a hemiarthroplasty, just because I think the risk of loosening the glenoid is outweighed by glenoid erosion. I think if they have, a desk job and moderate activity, running, cardio, light weights, then I'd probably lean more towards a total shoulder. It's not implant specific. It's more patient specific.
Thank you.
Thank you. Joe, 2 questions here. In a young arthritic knee on the glenoid side, is there a role of a run and ream kind of scenario?
So yes, I do believe there is a role for it. We've not had as much success at our institution as Dr. Madsen has shown at the University of Washington. So I think, again, this is one of those operations where we tend to tell them that the first year you really have to push and rehab hard because they seem to have a lot of pain. And I think it does create that fibrocartilage for them. And Rick Madsen, is a great researcher and has shown excellent results. Again, it's one of those things that I think he does it so often, but he's gotten so good at it that we do it, 3 to 5 times a year at max. And I think we get okay results. The other thing that, in concentric glenoids that I will do is I will ream them lightly, and then I will just make sure I vent their glenoid by drilling multiple holes into their glenoid. And I think that seems to have some benefit.
Another question, Joe, is in a very young adolescent arthritic shoulders, are there a role of interpositional arthroplasty?
In my practice, no. And that's just because the data that I saw back in around 2002 to 2005 was not really that encouraging. And I think that there are people that can do it arthroscopically, but it's pretty challenging arthroscopic procedure. If you do it open, you are burning bridges. You're violating typically the subscap. You're putting implants in there, opening them to risk of infection. And, you know, I just remember seeing scopes of these patients, and the meniscus or whatever surface that you used was in the back of the joint, just as a, you know, foreign body, basically.
Yeah, Samanta, any question on your Shreyash? Yes, Shreyash.
Yeah. So you showed that example of a GLAD defect. Now, to what size of lesions would you just do a microfracture versus that particulated, you know, allograft chips which you put in that case?
Well, I think if they're, and this lady was 47, so she's on the relatively younger side. It was a contained defect, and it was, you know, central but reasonably small. And I think in that situation, I would use this biocartilage. If it was, you know, uncontained defect, bit older patient, maybe, you know, mid-50s, I find it by accident, meaning they have shoulder pain, but I didn't expect to see a chondral lesion, then I will do microfracture. I don't use the micronized extracellular matrix that often. I tend to use it actually in my 20, 25-year-olds who had some trauma, who I'm suspicious they've had a chondral lesion, and I go in there and I find it, and I try to fill it for them. And I've had good success with it, and I've been happy with it. So I think it's a good option. I think it's worthwhile in the younger population to give them an extra chance. I'm not sure it's really worthwhile in the older population. And I think it could be a costly option for not much gain.
Right. Another question along the same lines of that GLAD lesion is that should we think of doing some sort of a cartilage procedure like a micro drilling or microfracture for every GLAD lesion we see? Because quite often in the chronic cases, we do see this. So is it worthwhile doing that prophylactically so that they don't have an issue subsequently?
I don't think so. No, I mean, what I've seen is I thought her lesion was a little more central than anterior. And what I've seen is in patients who have instability and recurrent instability, they do typically get some cartilage erosion anteriorly, but it's once you fix their labrum and stabilize their shoulder, it doesn't seem to be that painful. The patients that seem to have more pain are the posterior labral patients. So if you have a posterior labral patient with cartilage loss posteriorly and you fix their labrum, but their glenoid is still devoid of cartilage and is not covered, they tend to have more problems. And I think it's just because of the way the humeral head is generally resting in a retroverted position and with pressure there. We've seen in our paper on posterior labral repairs a greater propensity of those patients that are young, but over 35, to go on to needing an arthroplasty because they have progression of arthritis and pain. So
right.
For the posterior patients, you may need to do a microfracture on or something for the cartilage than the anterior patients.
And on the chat for the same case, there is a question which says, so what was the reason for the recurrent episodes of instability after the Bankard's repair? Is it cartilage or what else?
I think it's oftentimes this perception of patients that they're unstable, but it's actually they're falling into a divot or some sort of imperfection in their joint surface, and it feels like they're falling out. And you see that sometimes in patients who have more arthritis than this lady. But, again, it goes back to there are some subtleties that you need to appreciate even on the examination under anesthesia and be careful because everything seemed like, well, maybe we should just do a ladder J on this lady. And that probably would not have made her happy.
Right. And when you see these focal defects either on the humerus or glenoid or bipolar, is it fair to say that from what evidence we have, if there is an isolated focal defect on the humeral head, it would be much better in terms of patient outcome versus an isolated defect on the glenoid side? In short, the glenoid is more unforgiving if there is a cartilage issue compared to the humeral.
I think anecdotally that's true. I don't have any data to prove that, but it's a level 5. Level 5, yes, I would agree with you.
The only issue with addressing these focal defects on the humeral head is the access, especially arthroscopically. You have a lesion on the humeral head. So would you not hesitate to kind of go ahead and do it open to make sure, or does it really matter and just chondroplasty would be enough arthroscopically?
I think, yes, I think it's more challenging to do it on the humeral side. I think it is possible to do it arthroscopically on the humeral side. Again, if it was a focal defect in the central portion of the humeral head, then I would, and a young patient, I would probably do a microfracture and use, a cartilage substitute as well. I think you can do it if it's a small defect arthroscopically. If it's a very large defect, that's a different problem.
Right. Swarnendu?
Joe, I've got a question, because in India we see some sort of recurrent dislocation shoulder, those who are having probably 6, 7, 8 dislocations, and we're happy with the Bankart. It's not doing the other than the Bankart, but there's some defect in some articular cartilage irregularity on the glenoid side. Do you have any long-time experience? Does it, suppose like 10 years follow-up, do you follow this? What's your experience when you see this sort of glenoid defect in the recurrent dislocation shoulder?
I think, what we've seen from some of the larger studies that have been done is that, and this, these patients do go on to progressive glenoid arthrosis, but I think at a gradual level. So if you're seeing them in their 20s, they're probably going to, in 20 years, see somebody else, because most of us are either probably going to be retired or they're going to be in a different community because that's the nature of that population. And they're probably going to end up needing an arthroplasty as they get into their 50s. I had my shoulder stabilized 20 years ago, and it works well. I don't have any instability. I have a little bit of arthritis. Now, I'm not going to have an arthroplasty unless it becomes, severely painful, and it's not severely painful. But, I've had a follow-up MRI, and there's some early arthritic change, and I had an arthroscopic Bankart. I think the nature of the fact that, especially in the patients who let it dislocate multiple times, especially the fact that we operate on them, sometimes some of the materials that we use, we don't even know if they have some causes of arthrosis, such as the suture or the shaver debris, or a lot of things are potentially introduced to that environment for the patient. So I think their chance of getting arthritis is higher, as you know.
I think Rothman has a question.
Question I ask you, Joe, only because do you just explain the patient, probably at the long term you might be arthritic, and there might be probably your shoulder might be stable, but at least by 8-10 years time you might be arthritic. Do you discuss with this patient these probabilities, or just go ahead with?
Well, I discussed that with them, but I also temper it with, if you continue to dislocate, the chances of progressive further chondral damage, neurovascular injury, and safety issues are pretty high, especially if you are involved in athletics. I was a person personally that was dislocating in my sleep, and I actually dislocated on call in the ICU as an intern. And so I knew at that point, when I was sleeping in the intern call room, I had to have my shoulder fixed, because not only was it a danger to me, it was a danger to patients that I couldn't perform my duties when sleeping if I got called for an alert. So I think you have to tell them both sides of the story. They are more prone to arthritis, but I think recurrent instability, we know, can be very dangerous.
Roshan had a question.
Yeah, I had a question to Dr. Joe. Joe, it was a nice talk, and you spoke about the extracellular matrix and use of those materials in the use of early degenerative osteoarthritis of glenohumeral joint. So are there any trials which are going on? Because last when we spoke to Dr. Biraris from US, he told us about there are a lot of patch trials which are going on in United States, where they use biodegradable surface augmenting patches which can be placed on the glenoid side so that they can regenerate the articular cartilage to some extent. May not be the natural hyaline like, but at least a cartilage which can give some life to your shoulder joint. So are there any patches, and what is the outcome of those things, especially in young arthritic population who are involved in sports activity?
So I'm not involved in any trials with patches in the United States. I don't have any experience with that. I'd be interested in being involved, but they have not had significant market penetration, with our various companies in the States. So I don't have any experience with that. One of the things that if it's a patch material, much like even the what I showed, it's the shear forces that you worry about. How long will it take to incorporate before it shears off, right? And so that's the problem. And I think a lot of times because of the shear effects, it just peels right off. I don't know the right answer for that. A lot of people are talking about various injectables and stem cells, etc. It's something that we look at cautiously and have not been routinely utilizing. Some people use it to exploit patients for very high prices.
Second was the use of allograft, like what we started using allograft for our the femoral condyle defects, especially in the focal cartilage damage in knee joint. Can we use similar way to regenerate or to get a new articular cartilage in the form of structural allografts?
Yes, and I think that's been shown nicely by Brian Cole and others, that you can do that for focal defects in young patients in the humeral head in particular. Again, not to sound like a commercial for Arthrex, I have no conflict with Arthrex, but they do have a nice system for using fresh allograft and matching it to the patient and putting it in there for these, fairly unique lesions that you see in these patients. I think it's encouraging. It was interesting. Ruben Gobisi in Cleveland was talking about a allograft total shoulder arthroplasty a few years back, but that's kind of gone to the wayside because in that situation, I think, the patients had progressive resorption of the grafts and failure and progressive arthritis. But, I do think what you're saying makes sense in a young population that has these large defects and that you don't want to use maybe a small resurfacing focal implant.
Okay, great. So any last minute questions, guys?
No, I think we don't have any.
Yeah, I just wanted to know from Joe, what is the protocol, especially when we see nowadays with a lot of arthroscopic bankart, we see very young arthritic population, as Dr. Samanta was talking about. So what is the approach towards this young arthritic, especially the demanding young shoulders, like 25-year-old, 30-year-old male who is involved in, overhead throwing activities or racket activities or, throwing activities. So those patients, how do you face them? Because we have few mixed martial art players who got operated at early 25, and at the age of 30, 35, they come back with the early arthritic shoulder changes. So how do you approach those?
Yeah, I have a lot of patients like that as well, and I think that if your imaging isn't really that revealing, I have a low propensity to go in arthroscopically, and now some of these needle scopes can be useful as well. But I go in arthroscopically and look at the joint to see what's going on, because a lot of times the sutures have loosened, they're causing abrasion. They, at this point in their life, are actually a little bit too tight. They have synovitis. I get the sutures out. I will sometimes do a synovectomy, maybe a rotator interval release. I'm not going to disrupt their bankart repair in most situations. And then if they have some focal cartilage defects, I will microfracture them. And if young enough, consider some use of biocartilage in that area to see if I can help them. So, I think it's again, setting expectations. They need to know that, look, you're going down the path of progressive arthritis. We may be able to slow it, but the natural history of it says that at some point it's probably going to get bad enough that you need some further intervention.
Yeah, Joe, and as you rightly said, these cartilage procedures unfortunately don't do very well on the shoulder, unlike the knee, because the knee cartilage is much thicker compared to the thinner glenoid cartilage. So you're absolutely right. So we are in a dilemma. Great. So yes.
About 10 years ago, I was so interested in the fact that there'd be these patients that you don't see anything on MRI or X-ray, and you go in and they have these, focal cartilage defects that are sizable, that are grade 4. And we did a study on this, and, exactly what you said, because of the thinness of the cartilage on the glenohumeral joint, we often miss it. If we don't mention it to our patient, they're disappointed because they feel like you told them one thing was going on, and then you go in there and find something else. And now they're trying to figure out, what do you mean I have arthritis? And you didn't tell me this, and I didn't understand it. So we've done 2 studies on this, and it's pretty common, and it's often missed, and we miss it too because until we go in there arthroscopically.
Yes, Ram.
Yeah, thank you, Joe. That was a nice discussion. Just on a lighter note, you said you will discuss the outcome with the patient with the heart attack and divorce. Heart attack, understandable. What is divorce in shoulder?
Well, I think it's just the matter of the pain of life sometimes. You need to mature and realize that you're not always right. And I think that as a young person and being sometimes stubborn and foolish, you tend to think that surgery is going to return you back to your 20s. And so I think the pain of just experience in life, I don't necessarily think we should all get divorced, but I think the experience of life teaches you a lot and tempers your expectations.
Great.
Thank you.
Right. With that, we'll, yes, Swarnendu.
No, I think that's a great, we are really honored that Joe, you just had an excellent presentation. We really enjoyed it. Thanks a lot.
Thank you so much for the honor and privilege of speaking to you all. I look forward to meeting you in person.
Yeah, Joe, thank you very much on behalf of both societies and myself. Really, you were very prompt replying to my invitation, and hats off taking time off on this Thanksgiving holiday. And we wish you well, and we look forward to communicating in the future. Thanks a lot.
Thank you so much.
You take care. Thank you. Bye.
Bye-bye.
It was a wonderful webinar today, all arranged by Dr. Shreyash. Thank you, Joe, for this wonderful webinar. Upcoming next weekend on Friday at 8 p.m., we have a webinar on arthroscopic subscapularis augmentation. Our professor and the master speaker is Dr. Christos Kukos. He's from Germany. And I think this will be an interesting topic about subscapularis tears. He talks about arthroscopic subscapularis augmentation. Do tune in to Indian Arthroscopic Society YouTube channel on 4th February, coming Friday at 8 p.m. Have a nice day. Take care.